Hi, everyone, and welcome to Webinar Wednesday with Dr. Filomena Trindade. She will be addressing insulin resistance, diabetes, and the gut microbiome today. And thank you to all of you for attending. Now, Dr. Trindade, the floor is yours. Thanks so much.
Thank you so much, Melissa.
Of course.
Well, welcome, everyone. I always feel like I'm talking in a vacuum because I can't see you, but I will take questions, and so we'll be having some interaction. Now, when I talk about diabetes, I'm really also referring to the whole continuum, whether we're talking about insulin resistance, impaired glucose tolerance, prediabetes, or diabetes. I just wanted to say that from the beginning. And although there's many different underlying root causes or triggers for diabetes, in this case, I'm more specifically talking about type 2 diabetes, I'm mostly going to be focusing on the gut microbiome, although I will mention some of these other forces, so to speak. Now, for those of you who heard me talk before, you can't escape without a slide showing a picture of the island in the Azores, which is St. George, where I'm from originally and where I've been spending more and more time. It's sort of what keeps me sane. So I use these pictures to help me time myself, but also to balance my right brain, left brain, and to help you do the same, because we can really only pay attention and retain information for about 20 minutes. And I'm going to be talking for an hour, possibly over an hour. So we use pictures. You can also use sound. I just like pictures because they do help me shift, and I'm hoping it will help you shift, but it also helps me keep my cortisol levels down. Now, when we talk about insulin resistance, if you remember nothing else from what I said today, please remember this. And that is what I call the continuum of insulin resistance. Just like if you had wellness on one end and illness on the other, we're going to have patients coming into our doors that are going to be somewhere along the continuum, right? And many of them have no symptoms, but are already unwell. And some have symptoms, but yet their other doctors have told them that there's nothing wrong with their labs because they're mostly looking at laboratory reference ranges, and they're not really putting together, right, all of their symptoms to try and get to the underlying root cause. They're not connecting the dots. Well, with insulin resistance, let's look at it the same way. If you have the insulin sensitive person on one end and the diabetic type 2 on the other, we know it's not the have it or not phenomenon. It's where are you along the continuum? Because you could be insulin resistant and yet be suffering the consequences of impaired glucose tolerance, prediabetes, or even diabetes, right? You can have peripheral neuropathy, for instance, from insulin resistance. And we're seeing more and more patients that may not progress. They may be insulin resistant or impaired glucose tolerant or even pre-diabetic, and they may not progress to diabetes type 2. Yet many of our traditional colleagues are waiting for them to progress to type 2 diabetes to then start treatment. I know that I'm speaking to the choir in that sense, and we're not going to be doing that. But I just want you to be aware of the fact that you're going to see women with PCOS, for instance, men and women with obstructive sleep apnea. And in both of those conditions, there is underlying insulin resistance, where they may be insulin resistant and they may not progress to impaired glucose tolerant. Why is that important? Or to prediabetes or diabetes? Well, it's important because some of the tools that we have in our toolkit in terms of laboratory evaluations, you're going to look at them a little different. Because, for example, you can have someone who's insulin resistant and have a completely normal HOMA-IR, the homeostatic model of insulin resistance, because it only relies on fasting insulin and fasting glucose, right? Even though it's maybe a long formula. And you may have a normal hemoglobin A1C, and yet someone may be insulin resistant, because the first thing that will happen is the postprandial insulin will go up. Actually, before that, adiponectin will decrease in many patients, not all, but in many of them. So we need to start looking at other markers to try and identify patients earlier and earlier along this process, because then it's much easier to reverse. And as I always say, there is a cure for type 2 diabetes, but it is early diagnosis and aggressive intervention. And the earlier on that continuum that we identify patients, the easier it is to bring them back to normalcy. The other thing I wanted to also focus on before I go any further is in the difference between insulin resistance and metabolic syndrome, because I often hear my colleagues talk about them as if they were the same thing. Granted, according to the work of Gerald Reaven, we now know that insulin resistance has sort of emerged as one of the most important traits or factors in the metabolic syndrome. However, in order to say that someone has metabolic syndrome, they have to have 3 out of the 5 traits, whether it is elevated blood pressure, or elevated fasting glucose, or elevated triglycerides, or low HDL, or increased waist circumference. But they need to fulfill 3 of those, because I think we need to be really careful with the language that we use and the definitions of the terms that we use, especially when we're communicating with our more traditional colleagues. So if they have metabolic syndrome, remember they have to have 3 of the 5 traits. Although we're mostly going to be talking about insulin resistance, I just wanted to make sure I mentioned that because I come across that pretty often. Now, early on, my work or my background is in the nonprofit arena, where I see and was seeing a lot of uncontrolled diabetics, and particularly type 2 diabetics. And so my biggest angst and what I really wanted to get through with my patients is, well, how did this person develop diabetes? Or let's go a little bit further back, right? Let's go a little bit upstream. How did they develop insulin resistance? And so through looking at multitudes of data and papers and articles, I came up with this back in 2012. I actually copyrighted this list because I was trying to really personalize my approach, right? And that's all that you and I are doing, right? And you're already great at it, or you wouldn't be here. It's really looking for the underlying root cause and putting that together and personalizing our treatment for that particular patient, right? This is all about personalized precision medicine. So this list can be used not just for insulin resistance, although that's what I'm going to be talking about mostly today with a focus on the gut microbiome. I want you to be aware that you can use this for any disease process, any diagnosis, or any dysfunction, right? Because we're trying to diagnose patients earlier in that process. So think of things like food sensitivities or food allergies. Of course, I'm going to focus more on dysbiosis, leaky gut, and changes in the gut microbiota, but also consider food additives or food accesses, or insufficient digestion, whether it's at the level of the stomach, the pancreas, the gallbladder, or even the duodenum, which is that relay system or that communication system for digestion. But also think about mitochondrial dysfunction, oxidative stress, toxins. We have lots and lots of literature in all different types of toxins, where they are persistent pollutants or endocrine disruptors or heavy metals, and their contributions to insulin resistance. Obesity, of course, can be a cause, but more often than not, it's the insulin resistance that leads to the high numbers of obesity that we're seeing in the United States and throughout the world. And then more and more, we're having articles showing that changes in the HPA axis, especially stress and HPA axis dysfunction, could also be the trigger or one of the triggers or the underlying root cause for insulin resistance, as well as lack of sleep, changes in other hormones, and infections. And with infections, you want to look at all different types of infections. But viral, and with viral, you want to look at reactivated viral infections, bacterial, parasitic, but especially when I look at occult infections, such as dental infections, for instance. Think of nutrient deficiencies, prescription drugs. In particular, we know about the statins, but many different prescription drugs can lead to increased risk or even cause type 2 diabetes. And sometimes it could be a drug that the patient was on previously and may not be on currently. And then, of course, we know that genetics contributes, and there's some polymorphisms that you may be aware of, and particularly with a methylation cycle. But think of the fact that there could be also more than one cause. And more often than not, it's not just our genes, it's how we bathe, it's sort of the environment. It's what we do to ourselves and the environment that we bathe those genes on, or in rather. I'm going to just go through a few different ways in which we affect our gut microbiota and consider the non-caloric sweeteners. This study is looking at aspartame in particular, and we know that it can change the sort of composition or the equilibrium of the short-chain fatty acids, and it tends to increase propionate. So the three main short-chain fatty acids are butyrate, propionate, and acetate. Aspartame, we know it can affect the gut microbiota directly, but it can also do so by increasing propionate, which is highly gluconeogenic and can also have negative effects on insulin tolerance. And it may actually also cause damage to the pancreatic beta cell, because more and more we know that with respect to type 2 diabetes and insulin resistance, it's really all about what's happening at the level of the pancreatic beta cell. Omeprazole and the wide use of proton pump inhibitors is associated also with a microbial shift, and that can then be that initial trigger that causes changes in the gut microbiota. And we see that that can also set the stage for small intestinal bacterial overgrowth. And we are seeing more and more of this, or I should say, changes in the gut microbiome, in particular in patients who have liver disease. Food additives, remember, is one of the things on my list. In particular, I'm going to be talking about carrageenan for the next few minutes, because it's commonly found. It's still being found in things like chocolate milk, ice cream, almond milk, for instance. And again, that may also contribute to insulin resistance. In addition, I wanted you to also have a look at this article in particular. This is an article by Dr. Barbara Corky and her group, and it was published in 2014. And it's titled, "What Are We Putting into Our Food That Is Making Us Fat?" From food additives, the contaminants, and other contributors to obesity and insulin resistance. And in particular, she goes through a list of food additives, things that are actually considered food or food products that can cause damage to the pancreatic beta cell directly or indirectly by affecting changes in the gut microbiota or changing the permeability or increasing gut permeability. Now, for the last 8 to 10 years, we've had lots and lots of articles talking about the effect of the gut microbiota on glucose homeostasis and obesity. And basically, the literature has been there, but it was really difficult to sort of put it all together and figure out, well, exactly how does this happen? So there was quite a bit of different papers talking about different mechanisms, but and all of them sort of came to the conclusion that we need to look at the gut microbiota in a sense as sort of an environmental factor that can modulate insulin resistance, diabetes, and other metabolic diseases, and that the gut microbiota in itself, there's several different mechanisms by which it can lead to increase in inflammation and insulin resistance. But there wasn't sort of a common theme or a meta-analysis that said these are the most likely pathways or the pathways in which we have more literature support. That really didn't happen until this article came out in 2015. And it was really looking at all the different articles that had been previously published on ways in which changes in the gut microbiota contribute to insulin resistance and type 2 diabetes. But what it did is it narrowed down to 3. And for anyone that knows me knows that I love my rules of 2s or 3s, but in particular 3s, because it's an odd number. It's something I can usually remember. And if I can remember it, I can teach it to my patient and they'll be able to remember it too. And as I often say, a well-educated patient to me is a compliant patient and a successful patient. So I like sort of being able to break things down in a way that I can reach my patients and in turn teach them, because I feel that that is really going to help this path that we are on together and being able to improve their health, and in particular reverse insulin resistance or type 2 diabetes. So it was, to me, a major article because it really helped me sort of put everything together and figure out exactly what are the main ways in which changes in the gut microbiota contribute to insulin resistance, prediabetes, and diabetes. And those three main ways are by the LPS, short-chain fatty acids, and bile acids. So let's take each one of these. With respect to lipopolysaccharide, we all know that LPS is found in the cell walls of bacteria. And it's not the cell membranes, because bacteria don't have membranes, they have cell walls, and particularly gram-negative bacteria. And when the cell wall lyse or the cells lyse, then the LPS is removed, or I should say is released. And in general, we are able to break it down and sort of metabolize and eliminate it. However, in the presence of an unhealthy high-fat diet, sort of your standard American diet or the horrible American diet it's been often referred to, the LPS stays around, it binds to toll-like receptor 4, and it increases inflammation. The other way, with respect to short-chain fatty acids, we know that the gut microbiota, if they're there and they're there in sort of robust numbers and that's not dysbiotic, they should be taking in the dietary fibers, but the soluble fibers that we ingest, and convert them into butyrate, acetate, and propionate. And in particular, butyrate is really important because it's the fuel for the colonocytes, and it also is what helps protect, or I should say, what helps make that protective layer, the mucin layer. But we, as Americans, are ingesting very low amounts of fiber, and in particular, soluble fiber. So we have the problem that we don't have sufficient fiber for the gut microbiota to then make the short-chain fatty acids. And in addition, we have a dysbiotic gut microbiota so that you're not able to carry this out. The third way is the bile acids, which is that the gut microbiota, if they're there in robust numbers and sort of doing the work that they should be doing, they will convert our primary bile acids to our secondary bile acids. However, if we don't have a good sort of robust and diverse gut microbiome, then we're not able to do that. And so you have increase in your primary bile acids, which are very inflammatory. I like this study for a few different reasons. You know, I have a functional medicine background, and I take functional medicine to personalize my approach to patients. And although this article probably knows nothing about functional medicine, definitely never mentioned it, they had a very sort of functional approach in that they were really looking for the root cause, and they were connecting the dots about exactly how changes come about in the gut microbiota. So they talked about things like mode of birth and whether someone was breastfed or not, and the diet, and not just the diet that they're currently on, but what have they been on up until this point, as well as do they smoke, how active are they, do they drink alcohol? And they really sort of talked about this triangle of metabolism, immunity, and the gut microbiota, which I thought was really, really unique and important, because all those things are going to sort of determine just how robust and diverse your gut microbiota is. It was also interesting that they came to this conclusion, and they said that the collective evidences of today suggests that the gut microbiota may in fact act as an important mediator of a number of environmental factors triggering common diseases, including type 2 diabetes, and that perhaps in the future, we could have sort of a minimal microbiota administered as a slow release encapsulated microbial culture that could then be used in randomized controlled trials that would really help us to reverse insulin resistance. And especially if you were doing that together with a healthy diet that was rich in prebiotic fibers. So I find this a really important study. And I've already mentioned one, which is what are we putting into our food that's making us fat, by Dr. Porky. This is a second one that I really urge you to look at. Very well done. And they sort of lay the ground rules for me to be able to help explain not just the importance of figuring out what are the contributing factors to insulin resistance and type 2 diabetes in my patients, but how are we going to intervene? Now, for a long time, I don't know about you guys, but I'm the type of person that, I can't sleep at night when I'm pondering things. And when I'm trying to sort of figure out, it's kind of like watching my nephew play with his Legos. I'm always trying to see, how do these things fit together, and how is it that one contributes to another, and how can I connect the dots? And so then my next thought was, okay, I have my list of underlying potential triggers or causes of insulin resistance, and the gut microbiota is huge, and I understand the three main ways in which they can lead to insulin resistance. But what about leaky gut, and where does it come in? It's sort of how does that happen? Because I know that food sensitivities, toxins, infections can increase permeability. And so you will see effects on the pancreatic beta cell from that and cause inflammation. And you can also increase your insulin resistance that way. But exactly, what else happens? And this was a study that sort of really helped me figure that out in terms of how you have this increased cytokine production that can lead to insulin resistance, in addition to changes in the mucosal elements or the mucosa itself. And we know that this is different whether you're talking about diabetes type 1 or diabetes type 2, that in type 1 it's thought to be more of a virus related effect that causes the increase in permeability. Whereas in type 2, we have more the effect of lipopolysaccharide or even food sensitivities that can cause the increase in intestinal permeability. So putting it all together then, how is it that changes in the gut microbiota can lead to insulin resistance and obesity? So I like doing little bits of review if I can throughout, because I feel it helps us sort of remember things and sort of bring it home. So I hope that it's the same for you. So one way, it can modulate host nutrition and energy harvest, because the gut microbiota also is able to produce vitamins, and it's also very active in fermentation and breakdown of food components that are undigestible by us, in particular some of those fibers. And with respect to short-chain fatty acids, we're really talking about soluble fiber. It can also has an influence on intestinal epithelial homeostasis. It's involved in development of the host immune system as well as immune modulation. It protects us against pathogens. It's also very involved in drug metabolism as well as bile acid metabolism. And in addition, it's also very involved in metabolism of hormones, and particularly estrogen, for instance. I wanted to also just go back and do a little bit on history in terms of how our gut microbiome is modulated or sort of created based on what exposures we've had. And this study was amazing for that, because to me, a picture is worth 1,000 words. And so this is talking about how even in the unborn infant, sort of the nutritional status of the mother has a lot to do, and her own gut microbiome, with the development of the baby's gut microbiome, particularly during birth, as it's going through the birth canal. So it's important whether they were born vaginally or born by C-section, to the point that now some babies born by C-section, they will actually smear some of the vaginal fluid in the baby. And I know that's been controversial, and there's studies looking at it in support of and against stuff. Sort of there's pros and cons, but it is a factor you need to consider in terms of trying to figure out how did those changes in the gut microbiome come about. Also, too, whether they were breastfed or formula fed, and then what has happened throughout their lives. How many antibiotic treatments have they had? What kind of nutritional status have they been most of their life? And we know that in addition, just age, aging in of itself will cause changes in the gut microbiome, because the gut microbiome is really populated sort of during the first 15 months. So can you imagine a baby that is born and immediately goes to the neonatal intensive care unit, how that whatever sort of bacteria are present there may be what populates their microbiome, and how that sort of sets them up in terms of their future health, particularly if it happens in the first 15 months. The other thing you really want to consider is that the fact that we tend to go through quite a few doses, as the average person goes through quite a few doses of antibiotics, unfortunately. And the study was looking at one dose or I should say one course, 7-day course of clindamycin, 100 milligrams twice a day for 7 days. And when you follow that patient without giving them probiotics at the same time, 2 years later, there's still changes in the gut microbiome due to that 7-day course of antibiotics. So it's important that we consider that when we're talking to our patients. The other thing I want you to take into account is sort of the methylation cycle or the nutrition and the status of the B vitamins with our patients. And these are things that we can assess laboratorily, but we can also get an idea just by looking at someone's mucosa, looking in their mouth, looking at the tongue. There's a lot that you can tell. In particular, I always remember that papillary atrophy of the tongue is associated with low riboflavin. And riboflavin is extremely important in the methylation cycle. But you can also just get an idea in terms of the family history or that person's history. Do they have, multiple chemical sensitivities? Is there depression, anxiety, or schizophrenia in their family? And what about peripheral vascular disease or asthma? That's also associated with changes in the methylation. And of course, we can do our genomic testing, but when we can't, then I find that our history is extremely important, or at least even if you can, the history gives you an idea of where to hone in. And, I'm used to working with patients without insurance, and I've done a lot of work in the third world. And to me, trying to use our clinical skills as much as possible is really, really important, including our physical exam. Although I don't have a lot of time to go through that today, consider that in addition to looking in the mouth, just by doing a waist circumference, measuring waist to hip ratio, looking at the skin and the muscle bulk, there's so much that you can attain in terms of the health of a patient. Just looking in the mouth, for example, and looking at the tongue, if there's an enhanced lambda or the longitudinal fissure of the tongue, that's associated with an upregulated gut-associated lymphoid tissue. So you already can just look in the mouth and get an idea if that person is inflamed or the gut's inflamed. The other thing is, don't forget about the prior diagnoses. If your patients are anything like mine, they come to me with a long list of diseases. And in general, many of those are associated with insulin resistance, but we may not know that. In particular, obstructive sleep apnea or elevated liver function. So NASH, non-alcoholic steatohepatitis, or sometimes you'll just see an elevation in ALT, for instance. Consider that that's an underlying insulin resistance. And anyone who has a prior diagnosis of cancer, they're insulin resistant or proven otherwise. And we should be treating them as such. I think I already mentioned obstructive sleep apnea, but also polycystic ovarian syndrome, which we're seeing more and more, and we're seeing it more in younger women. And you can be insulin resistant in an organ and not necessarily be total body insulin resistant. So it's important that we take that into account. This is just a study looking at the fact that insulin resistance is associated with obstructive sleep apnea, and those patients have a greater risk for cardiovascular disease. So in the Azores, I live in the central group, and the central group is composed of 5 islands. I'm in the middle, and there's 2 on my south side and 2 on the north side. And in this picture, you can just see 2 islands, Pico and Fayal, in the distance there. Just a little shift in our brain. Let's just talk about what labs would we order, and then we'll go on to treatment, and I'll give you some of my treatment pearls. I divided this into initial and additional labs because sometimes we're not able to do everything at once. I really like looking at adiponectin. I was really excited when it came out and got released as a marker. Adiponectin is fat-derived. It's probably the only pro-inflammatory molecule. The only anti-inflammatory molecule that is made in the fat cell. And we know that adiponectin decreases before insulin increases. And when it came out, I was really excited because I wanted to be able to have a marker that I could use to determine whether someone was insulin resistant, even before their fasting insulin went up, or even their postprandial insulin. However, now that it's been out for a few years and we've been using it and there's more and more studies on it, we know that there are some people that they may be able to become insulin resistant and yet maintain their levels of adiponectin still pretty high. And we think that's more genetics. There isn't a lot of information in this area. So just be aware of that. Then we're going to look at our insulin, and I like doing fasting insulin, a 30-minute insulin after 75 gram load, a 1 hour and a 2 hour. And the reason I do that is because Dr. David Ludwig talked about some people being early secretors, and that is that the insulin may increase at the 30-minute time after they are challenged with a 75 gram glucose load, for instance. And if you measure at the 1 hour, it may seem normal. So just food for thought. There's not a lot of literature on this, but I like doing a 30-minute, 1 hour, and a 2 hour because I find that I catch patients better that way. And proinsulin, there's been lots of literature around proinsulin as a marker of pancreatic beta cell dysfunction. I use it. I have to say it hasn't been as useful to me as I initially thought it would be, because I feel that even an uncontrolled diabetic who's been in control for years, I'm able to sometimes get him back to a completely normal hemoglobin A1C of 5.3 or less. But it is a great tool to use initially if you're trying to see if there is already lots of pancreatic beta cell dysfunction. And David Futzner out of Germany actually has done quite a bit of study in this area, and he's actually divided the levels of proinsulin into 6 stages. If you're interested, you can look up his work. Then I feel it's really important that we also look at expanded lipid profiles by nuclear magnetic resonance. Sometimes you may see changes in the lipoprotein profile before you see changes in the insulin. Initially, it looked like this was always going to be true. Now, actually, we realize that it may be true in some patients, but not always, and definitely not in all patients. And then we want to look at our more traditional factors like your comprehensive metabolic panel, but we're going to look at it through what I call functional eyes in a sense. Because, for example, if you look at fasting glucose, we know that risk starts at a fasting glucose above 75. And for every number above 75, so if it's 76 or 77, so every one number is associated with a 1% increase in cardiovascular risk. So if you fasting insulin is 85, then you have a 10% increased risk of cardiovascular risk just based on your fasting glucose. The other thing is that just looking at your alkaline phosphatase, for instance, we know that alkaline phosphatase, if it is 80 or less, I should say usually less than 80, then that patient is probably deficient in magnesium and zinc, because that's one of the cofactors. And although the reference range is huge, you usually want them around 80 or a little bit higher. You don't want it too high either, or if it is, you need to figure out why. The other is GGTP, which unfortunately was taken out of the comprehensive metabolic panel, and we have to order it separate. But I consider GGTP sort of my poor person's measure of glutathione. And if GGTP is above 25, then that means that their glutathione reserve is low. And that has been really useful to me, particularly if I'm not able to measure glutathione, and now in times of COVID. The other thing is uric acid. I hope you've all read Dr. David Perlmutter's most recent book called Drop Acid. He takes us through all the different studies looking at uric acid and how small changes in uric acid, where it's still considered within the reference range, are indicative of someone being insulin resistant, and it's an independent risk factor for cardiovascular disease. And in his book, he talks about 4.8 being the marker for women and 5.2 for men. So I kind of round it off and I look at I look at keeping uric acid levels to 5 or less. And that way I don't have to memorize both. And then also consider looking at a comprehensive digestive stool analysis, a particular one that also looks at the gut microbiota and looks at the commensals and sort of tests for how robust they are and exactly what the diversity is. And when you talk about comprehensive stool analysis, there's a couple other things that I find extremely important to also look at. And that is that you can look at the microbiology. So you're going to look at the microbiome diversity, right? But you can also look at the microbiology in terms of potentially pathogenic bacteria, fungi, parasites. And then you're also going to look at, of course, the good bacteria in sense that are you able to culture your lactobacillus and bifidus, for instance, or your bifidobacterium, I should say. But then you can also look at levels of your short chain fatty acids. And in addition, you get an idea of pancreatic function, right? Because you can look at pancreatic elastase. But even further, you get an idea about digestion also, because you can look for products of protein digestion, products of fat, and products of fibers. And so that gives you a lot of information to work back and try and figure out just how digestion is occurring or the lack thereof. So to me, the comprehensive stool analysis is really important, in particular one that also looks at what is happening with the microbiome. This is an example of the GI effects, for example, from Genova, and looking at the commensals, which, by the way, coming in the near future, they're going to have a whole new analysis of the microbiome and going to be doing microbiome testing. But in addition, you can look at pancreatic elastase, and you also look at markers of inflammation, such as what is the level of calprotectin and eosinophil protein X, and what about the IgA? Because if IgA is elevated, it gives you an idea that most likely there's a food sensitivity going on. It doesn't tell you which, but it tells you that there is, and then you can decide, are we going to do a further testing, for instance, or are we going to do an elimination diet with very close reintroduction so you can get an idea as to exactly what the patient's reacting to. And then, of course, your short chain fatty acids, as I had already mentioned. And then you can also get an idea about the bacteria, whether it's pathogenic or potentially pathogenic, as well as you're looking at parasites. My additional labs, which if I'm able to, I will do initially, but sometimes there may be I may be drawing too much blood, and Quest already thinks that I'm the vampire doctor. So I try to educate my patients and figure out if there's some tests that has already been done by another provider, I'll utilize those. If not, then we may do them at different increments. So the follow-up labs would be something like your vitamin D, the 25 hydroxy vitamin D, although you may choose to do it initially if you're able to, your homocysteine, your LP-little-a, your high sensitivity CRP. And don't forget about looking for celiac in some of these patients. I diagnosed an 85-year-old patient with celiac who had suffered all her life, unfortunately, and I wish that it had been diagnosed earlier. In addition, you can also do the genetic testing for celiac, so the HLA, DQ2, and DQ8. I like doing a nutrient analysis on all my patients, and you can also do a breath test. In particular, whether you're looking for hydrogen or methane, it's one of the probably the least ones that I use, because I feel that I can get an idea just from their symptoms as well as what I get in the GI effects. But just realize that it's really about you tailoring it to your needs and what you do best. In my island, we have a lot of different pools. And of course, this was a volcanic island, and we actually had a volcano semi-erupt just 2 months ago. I say semi because it started to shake, and then it fortunately calmed down and never actually erupted. There was no lava flow. But I just wanted to give you an idea of some of these beautiful pools, and there's different sizes so that you can sort of learn how to swim, if you will, because some of the depth may be only 3 feet, others may be 5, and others may be 8. And this is how we learn how to swim. We would go from low tide on the 3-foot pool, which by then it would only be about 1.5 feet, to high tide, and then to the medium size, or I should say medium depth pool. And then once you got to the deeper one, you were ready to go out on the ocean. And that is still something that I really enjoy. And that brings me also to mentioning the fact that movement is so important in our patients. And most of my patients don't react very well when I tell them to exercise, but they react much better, or they respond much better when I tell them that they need to move. And so we need to figure out, how does their body like to move, and what do they enjoy? What do they like to do? You know, I don't like going to the gym, but I love getting on my stand-up paddleboard. I love swimming. I love dancing. You know, I love doing yoga, and I love hiking. And all those things are movement. And it's really important that we try and really get to the bottom of those triggers and mediators in our patient. And in particular, the lack of movement and the lack of enjoyment in life is so, so important. So is diet, right? And we know that the standard American diet, which is high in saturated fats and very low in fiber and high in refined sugars and very high in sodium, and it's now been supersized, is horrible. And unfortunately, we're spreading it to the rest of the world. So we want to make sure that we're asking the right questions and trying to figure out what environment have our patients sort of bathe their genes in, if you will. What kind of diet have they had most of their life? And then we know now more and more, we have studies showing how the Western diet really changes our gut microbiome, as well as our immune status in general. And so my approach is really to start with the basics. And the basics is really looking at diet and lifestyle. And in particular, nutritional support with organic, wholesome, fresh, unprocessed, colorful, high fiber, and fermented foods. That also includes nuts and seeds. And in particular, I want to make sure that they're eating like the rainbow and that they're getting all different colors every day. And in particular, we aim for 5 different colors a week, but I try to go even higher than that. And so on my YouTube channel, I've created videos on how patients can get high amounts of fiber and varied in color every day. So I teach them how to make soups that are cream, like cream of vegetables, whether it's cream of asparagus or cream of broccoli or cream of carrot. And then you add other vegetables to that, so that in one serving, or say in one meal, you may be getting 5 or 6 servings already, because I want them to have 10 to 12 servings of vegetables and fruit, and the fruit has to be the low glycemic load. So basically your berries and kiwi, for instance. And when we're talking about those 10 to 12 servings, a half a cup of something cooked is a serving, and 1 cup raw is also a serving. But there you're getting most of your insoluble fiber. For your soluble fiber, those are your nuts and seeds, and I'll go through that in just a little while. But this would be more of your things like your flaxseed and your chia seeds and chestnuts, which are very, very high in butyrate, as well as coconut flour. And you can also use your supplemental fibers, right? I like acacia fiber, and there's also the modified citrus pectin. Acacia fiber I use quite a bit with really good results when you're trying to increase the butyrate, and you're also trying to increase someone's ability to sort of clear toxins and to break down hormones, especially for granulation. So you're going to start with your basis with that, and then you're going to address or modify the gut microbiota. You're going to try and fix the underlying root causes, because there may be more than one. You're going to decrease insulin stimulation. You're going to utilize and personalize the elimination diet. And you really are going to address and support lifestyle modification. And you're going to focus on digestion with how many times they chew their food. In addition, we're going to discuss just what type and how much movement they're going to be doing, as well as sleep. Then we're going to develop our targeted supplementation. But that is to augment all these other changes that we've already done. And we're really going to focus on that mind, body, spirit connection. Do they have a spiritual practice, and who is their support system? And do they belong to some kind of a group that really supports them and these new lifestyle modifications that they're doing? And if they don't, then maybe you're going to help them create one. And because I like the rule of threes, I've cut this down to 3, my rule of threes, which is to address insulin resistance with a big focus on the gut microbiota. And number 1 is decrease insulin stimulation. Number 2 is modify the gut microbiota. And number 3 is increase your cellular responsiveness to insulin. And so by decreasing insulin stimulation, it's a lot of what I already mentioned, is those 10 to 12 servings of vegetables and fruit, and then 35 grams of soluble fiber per day, which usually equals to 2 tablespoons of flaxseed meal, 2 tablespoons of chia seeds. And you can sprinkle these in anything. You can make chia crackers. I also have that on my YouTube channel. And usually 1 to 2 tablespoons of coconut flour, which you can add to food. You can thicken soups with. And usually I have them do 4 to 6 chestnuts a day. In addition, you can also add your acacia fiber to get to that 35 grams, depending on what each patient likes. And then you want to educate them about good and bad fats, just like complex carbs and simple carbs, and making sure that they're eating protein with every meal. And in here, you're also going to talk about movement or exercise, because that's also going to help decrease insulin stimulation. With respect to the gut microbiota, we know it's food first. Within 24 hours of instituting changes in your diet, you can see effects in the gut microbiota. And I use a lot of fermented foods, and I especially like helping my patients make their own kefirs or their own fermented vegetables or their own yogurt, and most of them are non-dairy. And you want to make sure that you're also starting your probiotics as well as additional prebiotics. Intermittent fasting, we know, also really helps the gut microbiome. And then we want to try and teach our patients how they're going to do this. So, for instance, I try to make it simple for them. So I tell them exactly which starter I want them to use for their kefir or even their fermented vegetables. And I like using Lactobacillus plantarum. There's quite a bit of literature around Lactobacillus plantarum. I have a slide coming up on it too in just a few minutes. But Lactobacillus plantarum has found to digest oxalates as well as histamine. So then in my histamine sensitive patients, I don't have to worry so much about putting them on a low histamine diet. I just have them take that as a supplement. In addition, I'm using it to ferment their food, because fermented food usually is higher in histamine. But if you're using Lactobacillus plantarum, then it's going to be lower in histamine. And then by increasing cellular responsiveness to insulin, what do I mean there? Well, again, exercise is going to do it, or movement, but also all our herbs and spices. And I want my patients to eat lots of different herbs and spices. With respect to herbs, you want things like thyme and dill and rosemary, and really introduce them into whether it's a stir fry that they're doing or a salad or sprinkling on their soup, just getting used to eating it every day, several times a day. With respect to spices, things like cinnamon and nutmeg, these are all, or cardamom, for instance, or clove, these are all spices that are very anti-inflammatory, and some of them have very high ORAC values. And so we're also adding those antioxidants to the diet, and we're really helping insulin and insulin resistance. And then, of course, we have our supplements, things like your Curcumin, your vitamin D, your magnesium, your omega-3s, and your curcumin. But that, to me, is added on in addition to your foundation, because then you have this synergism. And I'm often asked what elimination diet I use. I really like the one by Tom Maltier. This is the book that he wrote. He excels at how you do the reintroduction part, because that's extremely important. He also has great recipes. And then we're going to also look at how do we get rid of sugar in the diet. But we know that sometimes we may not be able to get rid of it completely, but just by limiting it by 5 to 10% of their total caloric intake, we have studies showing how the effects on insulin resistance could be minimized, and lowering high fructose corn syrup, because one of the main causes for elevated uric acid, or uric acid above 5, is high fructose corn syrup. And the fact that it's been widely used and it's added to almost any prepackaged food, even sometimes foods that are not necessarily sweet, or they don't taste sweet. And then those non-caloric sweeteners that I mentioned earlier, we have more and more studies talking about how negligent it is, in a sense, to continue to use them, especially due to their effects on the gut microbiota, but yet they continue to be in use and widely spreading. And then we also want to talk about the fact that we want to do all that's possible to increase the ability, or to protect, I should say, I was going to say increase the mucin layer, but protect that mucin layer. And this is what I referred to earlier, and I just wanted to leave you with a study. So this study was looking at the fact that when the microbiota is not fed, so you don't have sufficient fiber in the diet, in particular soluble fiber, then it will eat away at that mucin layer, and so it will become denuded, and you'll have barrier dysfunction just because the microbiota is not fed. And I remember I told you that the colonocytes are fed predominantly with butyrate. And this is just a few studies. I wanted to leave you with a few references that you can use for your patients. This is looking at the effects of prebiotics and probiotics in the gut microbiota, and really saying how that should be sort of your pharmacological target when you're looking at obesity and insulin resistance and type 2 diabetes. I'm often asked sort of what is the best diet for the insulin resistant patient? Well, more and more studies are showing it's really the Mediterranean diet, but not the Mediterranean diet where you eat a lot of pasta, but sort of your traditional Mediterranean diet, in which, and especially more of your southern Mediterranean area, where you're eating fish and lots of vegetables. It's more plant-based. And of course, then you have your protein, but you're eating sort of a colorful, wide range of plants in addition to your protein base. This is really talking about how by making changes in the barrier integrity and the gut microbiota, then you can sort of correct or decrease the effects on the different organs, and in particular the pancreatic beta cell. Because we know that when you have loss of barrier integrity, then you have higher circulating antigen load, and that can affect the pancreatic beta cell. But now we know that by increasing antioxidants in the diet, even if you do nothing else or some probiotics, you can actually lower that, because you can sort of restore that barrier function. This is another study looking at how you minimize endotoxemia with flavonoids, probiotics, and prebiotics. And you can also look at evaluating the intestinal alkaline phosphatase activity, because that will then help you decrease the inflammatory effects of the lipopolysaccharide, particularly if you have high amounts of lipopolysaccharide where it's not being broken down. And I mentioned earlier how the gut microbiota can be particularly manipulated by antibiotics, but we know it can also be manipulated by probiotics and prebiotics. And prebiotics can affect the microbiota directly by modulating its bacterial content, but also indirectly through bacteriocins that are produced by the probiotic themselves. And remember that when we talk about soluble fiber, in essence, we are talking about prebiotics, right? Because they are going to help the gut microbiota then make those short chain fatty acids, and in particular, butyrate, which we know is not just going to feed the colonic mucosa, but it's also going to protect that mucin layer or help rebuild the mucin layer. This is a systematic review of different studies looking at probiotics and glycemic control. And this is particularly looking at the outcome being plasma glucose, postprandial blood glucose, hemoglobin A1C, insulin resistance, and the onset of diabetes. So there's quite a bit of study. And this is another article that I would really encourage you to read. That's now 3 that I've given you that you may want to look at. Now I'm going to take you through the sort of probiotic strains that have the most information in terms of either reversing type 2 diabetes or helping your reverse insulin resistance, and actually sort of correcting the gut microbiota when it comes to insulin resistance. And Lactobacillus rhamnosus is one that's been around a long time. It's over the counter. There's actually a infant formula for colic, but there's interesting studies on Lactobacillus rhamnosus. This is a study done on mice where they had sort of the control food or the control chow, and then they had a very fattening, what I call my fast food chow. And in the patients that received, the mice in this case, they received the fast food chow. If they were given the Lactobacillus rhamnosus, they did not gain weight. Which is not to say that we can just give our patients a probiotic and not do anything else, but it is to say just how much we have in terms of tools in our toolkit to help our patients. This is looking at Lactobacillus gasseri BNR 17. And it's difficult sometimes to find one probiotic that has all of these strains. There are some out there that will have several of them, but I'm just giving you different ones that you can choose from. The other is Lactobacillus casei, has also been shown to help, especially in postprandial glucose levels and the development of hyperglycemia. More and more now we're seeing VSL number 3 in general in the market, but it's now under this biome. It's a very high potency probiotic. It's 8 strains of lactobacilli. It is available in a capsule, which is 112 colony forming units, or in a sachet, which is 450 billion colony forming units. So I prefer the sachet. The VSL number 3, now available as this biome, as I said, but the original studies were on VSL 3, has also been used a lot in inflammatory bowel disease, in particular ulcerative colitis. But now we're seeing studies of using it together, in this case, for example, with omega-3. This is a study on Lactobacillus plantarum that I had mentioned. And then we just know about the importance of prebiotics, and I wanted to give you a few different studies so that I wasn't just sort of giving you one reference. And we know that in some countries, they're actually looking at doing fecal transplants. In the United States, it's only approved for the treatment of C. difficile, and especially those that are resistant to antibiotics. But I just need you to be aware that more and more we're seeing studies about using it in terms of reversing type 2 diabetes also. This is the diabetes prevention trial, and it was just talking about the importance of physical activity as well as changing someone's nutritional status or their diet. But the important thing I found in this study is that, of course, the patients that did the lifestyle modification decreased the incidence of type 2 diabetes almost twice as much as those that were on metformin alone. But there's one thing really important about the study that I find, as I always mention, is that the patients that were in the lifestyle group, they were followed very closely. They met together every 2 weeks, and they received a phone call every week. And so this speaks to me about support and how we need to really talk to our patients, not just sort of the effects of glycemic load, which is really important, but also sort of the company it keeps and how they're eating and everything they're putting in their mouth, whether it is those herbs and spices, but also, do they have support? And are they sitting down to eat, or are they eating on the rush? You know, it's extremely important. If we are going to ask someone to do some calorie restriction, for example, as this article showed, then what is going on in terms of their stress or the stress in their life? It's all about balance and putting it all together. And we know that intermittent fasting is another one that has been popularized, and you have sort of the Jason Fong's version where he says for insulin resistance, 18 hours is best. And then you have Dr. Longo, which says, well, really it's 12 hours, because after that there may be some effects that are sort of counter what you would like. I think it's important that we start the patient and then take them as slowly as far as you feel they can go to reach the benefits that you'd like. And with respect to movement or exercise, I feel like sometimes we do need to put it this way with patients, right? We need to be really aggressive and say, you know, you can do high intensity interval training in 7 minutes. Do you have 7 minutes? And I can teach you how to do it. Or just, what do you like to do? What makes you feel good? And in terms of movement, and then sleep. Sleep is anabolic. It is so, so important. And we want to make sure our patients are getting 8 hours of sleep a night, because we know that even just 2 hours less a night for a week can make someone insulin resistant. And then just to finish, I'm going to go through sort of what are the factors that we would add to increase sort of the cellular responsiveness to insulin. And this is one of my favorite pools in the whole world. It's on the north side of my island. And every time I look at it, it just really, I find it very calming, even if I'm not there, but I'm just seeing a picture of it. And that brings me to also talking with our patients about stress. And if we're not able to remove them or help them get rid of a stressful situation, then we can help them cope, and we can work on sort of their way the body responds to stress. And some of these I already mentioned, things like chromium, alpha-lipoic acid, CoQ10, your vitamin D, curcumin, your omega-3 fatty acids. And I have a few different studies on each of these. We know about chromium with respect to insulin resistance and PCOS, but any patient with insulin resistance. And initially we thought we'd have to use really high levels of chromium. Now we know we don't want to go over 400 micrograms because it may be some toxic effects. Alpha-lipoic acid, it depends on if someone has polyneuropathy, but you can go up to 1,800 milligrams per day. And we're seeing more and more studies looking at combination products. So this is looking at omega-3 plus vitamin E. So just realize that although we do this in clinical practice, we also now have studies showing the same thing or testing the same thing. CoQ10. With CoQ10, you may want to go up a little higher. If you're measuring serum levels, you usually want your levels to be 3 if they have insulin resistance or diabetes or cardiovascular disease. But we know initially we had studies of 200 milligrams a day could actually improve your hemoglobin A1C as well as blood pressure. And vitamin D, now after COVID and all the studies that we have on vitamin D, I really aim for my patients to have a level of about 80 nanograms per milliliter, but we know that even small changes can make a huge difference. And curcumin, lots and lots of studies on curcumin from 1,000 to 4,000 milligrams per day. And in the last 3 years, we've had sort of an explosion on studies looking at curcumin and their effects, and even just the direct effects on the pancreatic beta cell. And we've looked at different types of curcumin. And then magnesium, one of my favorite minerals. If someone has normal kidney function and they are not a recipient of a kidney, or I should say, they're not they're compromised, then I take magnesium to bowel tolerance. Although I may measure levels, I really increase it to bowel tolerance. And this is just another study looking at the importance of magnesium with respect to insulin resistance. We're seeing more and more studies on polyphenols and combination products. This is using polyphenol and metformin, for instance. So just be aware that in the literature, we're starting to see more and more combinations, even with prescription drugs and some of the nutraceuticals that we utilize, which is, I find interesting and exciting because that's what we do in clinical practice. But we haven't always had those studies, and now we're starting to actually have them. So I'm going to go to some questions. And by the way, you can reach me on my website, drtrindade.com. I do hold retreats in my island, and I hope you come and join me for some of those. And in addition, I do mentoring, and you can keep up with me if you visit my website. So let's see, there's a couple under Q&A and then under chat. Will a recording be available? I'm not sure. I think these are recorded, but Melissa, do we have a recording available?
Yep. Yeah, I answered that in the chat. That will be sent tomorrow in an email to everyone. So there will be a recording.
Great. Okay. Now let's see. What are the cutoffs you follow for 30-minute, 1 hour, and 2 hour postprandial insulin? Great question. So for 30 minutes, the only studies on this were done by Dr. Ludwig, and the cutoff was 50. His original study was 57.5, but I cut it off to 50. So at the 30 minutes, if it's above 50, then they're insulin resistant. At the 1 hour, it's 25. And we don't, and at the 2 hours, I actually use the same level, 25. But I'm trying to see what happens also between the 1 hour and the 2 hour, because sometimes what you'll see is that you may go actually really low at the 2 hour, and you may have been above 25. Let's say you were 30 or 35 at the 1 hour. So it gives me an idea exactly what's happening with that beta cell or insulin regulation. So 50 and 25. First time I heard, oh, wait a second. I think I just jumped ahead. Can we get a list of the mentioned studies? Well, you're going to get a PDF of the of my talk, so you'll be able to look up all those studies.
Yes, absolutely.
What type of support would be a good option related to those with insulin problem? I find that I'm not sure if you answer this, Melissa, but I find that with respect to patients who are insulin resistant, I do groups. So I'll just have like after one day a month after work, I'll just have a talk on insulin resistance, for example. And then what happened is I had quite a few patients that were interested on continuing on. And so then we continued to meet, and we actually did some of that through video now with COVID. But I think to me, the most important thing is accountability and giving patients support. So sometimes they may even meet together and I may not be there. But it's all about them helping each other and forming these bonds where we're all contributing. There are support services. There's the Mendoza website, and through some of the senior centers, they will also have some support groups. I find that in many cases, they may follow the ADA recommendations on those. And so I'm pretty strict, and I prefer to just sort of hold my own or help my patients and work with my nutritionist to do our own. Which lab do you have a good experience to get some of the suggested tests, like the OGTT with multiple insulin levels? Actually, those I do at Quest and a LabCorp. I've just developed my own panels for them. Inevitably, though, they will mess up because usually what I do is I have patients go in fasting, and then they'll give them the 75-gram glucose load, and then they're going to test them at the 30 minutes, 1 hour, and 2 hours. And some patients will get really hypoglycemic. So even though Quest tells them not to eat, I tell them they will have a snack, and I want them to have a protein snack and some healthy fat. That's one option. The other option is I've created 2 panels. I have one where they will give them the 75-gram load. The other is I have patients do that themselves. I just tell them, you're going to cheat today and you're going to have 75 grams of glucose. I'm going to let you have syrup, and you can have your gluten-free pancakes, and you can have some orange juice, and which is going to put them over the 75 grams. But in any case, you can have them do that as long as they eat some protein along with it so that they don't crash. And then I have them show up close to 30 minutes later. And that in that case, in many cases, I want them to have an appointment. And so they can have the 30 minutes and the 1 hour. That's one way. And I just created both of those panels. One where I have them go in and do that test, and the others where they will actually give them the cola. Would you please comment on your protein amount recommendations? So with respect to protein, I find that in many cases, I either have patients who are eating too little protein or they're eating too much protein. So it's really all about how much do they need? And a lot of it depends on how active they are and what else is going on. Do they have liver problems? Do they have kidney problems? But I usually want to do, I go on that 1 to 1.25 or 1.5 milligram per kilogram, or gram per kilogram, not milligram. So 1 to 1.25, as high as would be 1.5 grams per kilogram body weight. And but the other rule of thumb is sort of looking at the palm, the size of their palm, and you want to eat a protein, the amount of protein, whether you're talking about a meat or fish, that is about that size in terms of, you don't want to overdo it, but you want to make sure that they're getting some protein. For my vegan patients, it's a little bit more difficult, or my vegetarian patients, because you have to really start to look at the amount of protein. Like people will eat quinoa and they say, well, it's really high protein. Well, it has some protein in it, thank goodness, yes, but it also, has some starch, and depending on which type of quinoa it is. So you just want to make sure that we're educating, and that you're looking at, lentils versus garbanzos, for instance, if it's a vegetarian patient, and start to really look at sort of how much protein is there in each, and making sure that they're having protein and a healthy fat. So to me, everybody's going to cheat. We're all humans, right? At one point or another, you're going to not be able to resist that birthday cake or your son's wedding. Something's going to happen. And so my thing is cheat smartly. So if you're going to have something that's higher glycemic load, then make sure you're having some protein, you're having lots of fiber, so you're going to eat your vegetables, and you're having a healthy fat. Whether it's avocado or you put extra virgin olive oil, a little bit more in your salad, it's all about balance. And the fact that fiber and fat will keep your blood sugar prolonged. So instead of peaking, it may keep it it will never let it get as high, and it may spread it out a little bit longer, but at least you don't have those peaks and troughs, which is the worst for the brain. What is the place of metformin in correction of insulin resistance and dysbiosis? Are there any benefits between metformin and berberine? Yes, on both. So metformin is thought to actually work through increasing Akkermans and muciniphila. There's quite a few studies on that. It's been called into question at times because some people don't tolerate metformin very well. I'm not sure I have a really good explanation for that, other than that they may have sort of a very unhealthy microbiome and one that's not very diverse. And so that may be the effects. And with respect to berberine, again, it also does that. It also works at the level of the GLUT4 receptor. Berberine is also great for the lipid particles. As far as sweeteners, is stevia okay? So far, that is the only one that I'm okay with. We've had a couple concerns, but nothing that I have sort of instituted. So for now, stevia is the only one that I allow. I also do allow local honey in very small amounts because I think there's great benefits of that, but we just have to be careful with the sort of the glycemic response in that particular patient. And that's one of the things that these continuous glucose monitors are great for, because you can actually see the effects right away. And each patient is different, right? What increases someone's sugar may not increase another. What are the calls for the 30-minute? I already did that. Oh, thank you so much. First time I heard someone put together the diet and foods. I appreciate that. Which probiotics do you use or recommend? Hyperbiotic Pro 15. I used to use quite a bit of it because it had it had the KCI and the Reuteri. Just hyperbiotics in general. If you look at some of theirs, I use VSL or Visbiome now quite a bit. I also like Biome Pro from Metagenics because it has it's only lactobacillus and the bifidobacterium. And really, the most thing you want to do is you want to make sure that you has quite a few of the strains that I talked about, and you may not be able to get all of them, but you can usually get quite a few of them that are lactic acid producing in general. And if you can't sort of get all of them in one, then I usually split them. I'll maybe do 2 different probiotics, like usually Lactobacillus plantarum. I will do that by itself. You can find it by itself. The probiotics by Body Ecology, quite a few of those also have Lactobacillus plantarum in them. So just so that you know, but I like using Lactobacillus plantarum by itself because there's a few studies on it. I know it's best to use fresh vegetables. What are your feelings about plant-based meats like Impossible Burger? Most of my problem with some of those plant-based meat is that they're also filled with fillers. And I'm not saying that Impossible Burger is necessarily bad or one of them because I've only eaten it once and I can't remember the ingredients, to be perfectly honest. But if you look at some of those, they're filled with a lot of additives that we don't want. They're on that list from Dr. Barbara Corky. What are we putting into our food that's making us fat? So I try to do as much as I can with nature. If I can't grow it, and I usually try not to eat it, maybe with the exception of chocolate because I don't grow it, but it is grown. I think it's just important to pick your poison. In other words, picks are the least poisonous. And if maybe poison isn't the best word, but sort of the least harmful, and that doesn't also create more chaos or more stress in a patient's life. And try to really read the labels and see just how many additives there are, because in many cases, things that other people may consider healthy, when you go down the list and you see all the additives, they really are not. Dr. Gerald Reaven, one of the godfathers of insulin resistance, stated that serum insulin measurement is unreliable outside of clinical studies, and surrogates such as triglycerides and waist to hip ratio are cheap. I agree with him, but I also think that more and more now we know that we have good studies on insulin and pro-insulin. Unfortunately, he passed away, I believe last year or the year before, and he's made great contributions. I think that I want to look at all those markers, and that's why I talked about those: waist to hip ratio, circumference, waist circumference. Like I always say, the cheapest probably tool in my toolkit is my tape measure, and definitely triglycerides. And I want to keep my triglycerides lower, even though with the some of the guidelines people are, and some of the reference ranges are still using 150, and we know we definitely want to keep them lower, and especially in women, it's an independent risk factor. So we want to look at all of those, but I think that more and more we're seeing that we have studies on insulin that it may not be so unstable, just like we have the studies on pro-insulin. So I think it's a measure of putting them all together, and that's why I also talked about your serum glucose, because if you have nothing else and that's your only measurement, then we know what risk begins. And I talked about being at 75. So I think it's important that we sort of put it all together. Which company do you recommend for dietary supplements purchase? Well, I use a variety of different companies. I like the curcumin quite a bit from Protocol for Life Balance. They're GMP certified, and which is really important. So with GMP, they follow good manufacturing practices. It's treated like it was a drug. It's tested for the raw materials, as well as it's treated like a drug in the sense that it's batch tested for amount, for accuracy, potency. And if someone has an adverse reaction, they can go back and look at that batch and make sure it wasn't a batch problem. So any company that's GMP certified, I will use. I use Nordic Naturals quite a bit. I like their Pro Omega blood sugar, because you get alpha lipoic acid, chromium, and 1,000 EPA and DHA, 200 of ALA, and 200 micrograms of the chromium, and that combination is great. I use Metagenics. I use a lot of their fish oil and some of their probiotics. I also use some of the products from biobotanical research, especially if one of the things that I'm doing is really trying to decrease that sort of postprandial load, and someone that is not being very sort of compliant. I really like their GI detox formula. So I use a variety of products. I also like some of the products from Designs for Health and some of the ones from Biotics Research. So it's really a matter of what do you want in your armamentarium, for instance. So fish oil, or I should say omega-3, and sometimes going up and above 3,000 milligrams, chromium, alpha lipoic acid, CoQ10, and curcumin are probably my top, and then my next would be berberine. What about alcohol sugars or sugar alcohols? Oh, this is a great question, because I actually wanted to mention that, because we have a lot of small intestinal bacterial overgrowth. And so we have a lot of people that don't tolerate sugar alcohols, period. So I don't use them for that reason. In general, I don't use them. And this whole sort of keto craze where you see all these keto products, but yet they're sweet. And it's because they're using a lot of these sugar alcohols. I think that, and we now have seen a couple studies, but I think that they are affecting your glucose load. They are affecting the pancreatic beta cell, and they are sometimes creating an insulin response. So I try to minimize them as much as possible, and just really work with patients to not crave sweetness, because when you remove that from the diet, it's no longer a craving. And especially if you're giving the body what it needs, you're giving them all these phytonutrients. Well, yeah, like erythritol or monk fruit. I still use a little bit of monk fruit in some of the recipes that I'm teaching patients where they want a little bit of sweetness. I'm still a little concerned, and I keep looking for studies. I like using stevia better just because it's been around sort of longer, or at least I should say some of the studies have been around longer. The thing with stevia, though, is in many cases they're using the stems and the leaf, and that gives you that acrid aftertaste. But if you buy the leaf only, it doesn't, and you can actually also use it for baking, because most of my patients will prefer to use a monk fruit for baking, for instance. Hi, Lynn. This is Lynn Patrick. These plant-based meats are made from GMO yeast or lab-grown tissue cells, lots of toxic ingredients. Please see my recent blog on the subject. Oh, great. So you have to look at, thanks, Lynn, on her recent blog. And thank you for that comment, because I really believe in farm to table. I grow most everything that I eat, including my own chickens. And after I read Omnivore's Dilemma, I decided that if I was going to be a carnivore, then I needed to be able to kill my own chickens. And that was really difficult for me. But, I sort of say my prayer and I do it because I feel like that's my responsibility. But mostly it's plant-based. And there's something about growing your own food and eating it. And I know not everybody's able to, but I have my patients even grow kale on a potted plant. Just got to make sure what soil you're using. And they can use their herbs the same way. You can put it on the windowsill. You can grow them in just water at times. So I feel like sometimes what seems like insurmountable really isn't, if you take baby steps and you do things that don't necessarily take a lot of time, but they become a habit and they're good for you. There's just something that fulfills your soul to a certain degree, as well as your cells. I'm talking about down to the cell membrane level, when you know where your food came from. And it's not always possible, but I try to do sort of the best that I can with my patients. Dark chocolate, 70 to 80%, an acceptable probiotic. Well, yes, but it all depends too. So where the chocolate came from, right? Is it organic? Because we know that a lot of it's grown in areas where leaded gasoline is still around, or they have other heavy metals in particular. But the other thing too about chocolate is that chocolate is considered an adaptogen, and that it can lower cortisol levels. So it really depends to me with chocolate on the caffeine, because you can get an idea if someone has a CYP 1A2 SNP, where if they do, you do not want to be increasing the amounts of caffeine. You're actually increasing their cardiovascular risk. So if they get sort of really wired, then it may lower the amount that I give them in terms of chocolate. Oh, thank you so much for your comments. I really appreciate. And there's something Ingrid said to everyone. I'm not sure what that is. And what about allulose? I don't know much about allulose. So please inform me and I will look it up. And with magnesium, see, there's one other question on here. Any hints for treating recalcitrant nocturnal hypoglycemia found on continuous glucose monitor despite diet, lifestyle, and appropriate supplements? Okay, in patients like that with a nocturnal hypoglycemia, you want to make sure that you're not talking about sleep apnea or some kind of a sleep problem, because you may be dealing with anoxia, and it may not be enough to qualify for CPAP, for instance, or even be diagnosed as obstructive sleep apnea, but they may have a sleep problem. Number one, you really want to look at that. The other thing that I would look at too is what's the glycemic load of what they're eating. And some of those patients, what I found is if I really increase the fat that they're consuming, the good fat in the evening, it may really help. Third is this someone who's had a lot of trauma? And they're maybe reliving it when they sleep and they don't know about it. So measuring the heart rate variability during sleep in many of those patients has really helped me. And also to try and figure out, what are we going to do? We're going to do neurofeedback. We're going to do brain spotting. Who am I going to refer them to? So those are the three main areas that I would look at. Oh, I don't see any upcoming retreats on my website. Well, it's because I'm still working on this year's. It's probably going to be in late August, early September. We just had really bad weather, and so I lost a lot of my crops, and everything that we pretty much eat, with the exception of fish, is grown, organically grown. And so I just didn't feel comfortable doing that. And I didn't have another farmer that I could share with. So that's what we're working on now, because our weather patterns have just been, really, really changed. We're going through our winter now, when this should be the peak of our summer. Which magnesium supplement best? Glycinate, threonate, etc. Great question. So I prefer glycinate sort of overall if I don't have a particular reason. If I'm more concerned about making sure that I'm getting in through the blood-brain barrier, I will use the threonate. If it's someone that might have more cardiac issues, I will use the magnesium taurate, because you're also getting the taurine. And sometimes I may even use a mixture. If there isn't an issue, or for example, if it's a fibromyalgia patient, I may use the malate. If that's not an issue, then I use the glycinate. Do you take any special approach if someone is already insulin dependent? Great question. I pretty much follow the same thing. I'm just a little bit more careful. And what I'll do is I usually will decrease their insulin level. A lot of them, they're on the ultra long acting. And so I may just decrease it by about 5 units initially, because I figure they're going to be more controlled. And I would rather they run a little bit high than to be hypoglycemic. But I've been able to sometimes get people completely off insulin, and others at least decrease it by half, if not. And in many of those cases that I wasn't able to get them off, it wasn't necessarily because there wasn't any pancreatic function left. It was more that the patient was sort of psychologically also dependent on it and didn't feel comfortable going any deeper, or they felt like they were sort of at the top of what they could do in terms of lifestyle modification. So I think that more often than not, I have been really surprised about just how much the pancreas forgives, in a sense. And one thing, though, that I am concerned about when some of those patients are insulin dependent that I wanted to mention is if they're LADAs, latent autoimmune diabetes of adulthood, where they're a type 1, 2. So they're a type 2, but they're becoming autoimmune. And those you have to be a little bit more careful, and you have to really try and figure out what the trigger was, because they may be having already antibodies to the actual pancreatic tissue, and those may be a little bit harder to get off insulin completely. But again, we're always trying to find that trigger, because we know that process can be reversed more often than not. You guys, thank you so much. I'll look up allulose, and I really appreciate your questions. I'll always learn more, I feel like, than what I teach. So I thank you for this opportunity.
Thank you, Dr. Trindade, and thank you everyone for listening. It's been such a pleasure, and thank you for all of your knowledge and your insightful answers to everyone's questions. We truly appreciate it. And as a gift to all of you, we have a special code for $100 off any course, but really, Dr. Trindade will be lecturing in our upcoming Women's Hormones course, as well as our upcoming Module 1, and you don't want to miss those. So use webinar 100 and you'll get $100 off, which is great. So thank you everyone again. And thank you so much, Dr. Trindade. It's been a pleasure as always.
Thank you to everyone. And thanks to you, Melissa.
Thank you.